Very warm welcome to all of you, and thank you so much for joining us for the first event in our new ongoing series, Emerge. We're so excited to have you with us tonight. I'm Maggie Harrington from Orphan Australia, and I'm honored and delighted to be moderating this event. The topic of tonight's session is ROTEM Update 2020. But before we dive into tonight's program, I'd like to tell you a bit more about Emerge and share with you the concept behind it. Emerge stands for Education Meetings for Expanding ROTEM-Guided Excellence. And the purpose of this series is to highlight evidence-based best practices for improving outcomes for bleeding patients of all etiologies. The core focus of these sessions is to harness knowledge transfer of ROTEM-guided patient blood management strategies to enhance patient safety, optimize resources, and reduce costs. We are absolutely ecstatic to have received almost 350 registrations for tonight's event. So it's fantastic to know there's interest out there for expert level ROTEM education. As we know your time is extremely valuable, the aim of the Emerge series is to deliver sharp and concise education sessions on ROTEM guided bleeding management from the leading experts in the field. So please be in touch with us to let us know what topics are important to you. Your feedback will help to drive the structure and content of our future events. So speaking of requesting your feedback, I'm just going to quickly move on to some housekeeping items. The first of which is a survey, which we'll have at the end of tonight's event. It's just a really quick survey, and the purpose is to find out how we can best tailor these sessions for you. Again, we really value your feedback, so please take a moment if you can to share your thoughts with us. Next, I'd like to quickly touch on some of the technical details regarding this Zoom session. First, I do want to let you know that this meeting is being recorded. Additionally, for anyone who's just joined the meeting, I'd like to repeat that this event is in a webinar format, meaning participants do not have access to audio or video functions, so we won't be able to see you or hear you. For that reason, if you have any questions, please feel free to pop them in the Q&A section, and all other comments can be posted in the chat. Please, if you can, refrain from using the raise your hand feature, as we will not be able to moderate this function in tonight's session. We will absolutely do our best to answer all questions live during the event, but for any questions we aren't able to get to due to time constraints, we'll be sure to publish a list of questions and answers in an email following the event. I also want to quickly inform you that we will have 2 interactive cases as part of tonight's presentation, for which you will be prompted to answer poll questions. The poll responses are completely anonymous, so don't worry about getting the wrong answer. We really just want to encourage everyone to participate as a learning opportunity. When the poll question pops up, you will have the ability to move the box to the side of your screen, unless you've connected to this meeting using your phone, in which case the poll box will likely cover the entire screen and you won't be able to move it. But just to let you know, we will keep the poll questions on the screen for about 30 seconds before removing them and showing the results from the group. Moving on now, I'll provide you with a quick overview of tonight's event. After the introductions, I'll hand the floor over to our expert speaker, and following his presentation, we will hold a short question and answer session, followed by a sneak peek of what's to come in Emerge 2021. So be sure you stick around to the end so you don't miss that. Finally, it's time for introductions. I'll quick give you first an intro to the members of our Orphan Australia team. All of whom have worked so tirelessly to make tonight's event a reality. So first from Brisbane, we have Natasha Curie, acute care diagnostics clinical specialist who covers the ROTEM training and education throughout Queensland and formerly in Victoria prior to her recent relocation. Next, from over in Perth, we have Julia Bonzer, also an acute care diagnostics clinical specialist who looks after ROTEM training and education in Western Australia, the Northern Territory, South Australia, and Tasmania. We also have with us tonight Kieran Pickles, our National Sales Manager, who is based here in Sydney. And once again, I'm Maggie Harrington, also an acute care diagnostics clinical specialist, and I look after the ROTEM training and education in New South Wales and the ACT. So now enough about us. It's time to introduce the star of tonight's event. Joining us this evening is a global ROTEM guru. He is one of the leading international experts in the management of coagulopathy who has dedicated his career to perfecting the art and science of hemostatic resuscitation. Over 26 years of experience working as an anesthetist, intensivist, and hemostasiologist at the University Hospital Essen in Germany has imparted him with extensive knowledge in the fields of trauma surgery and emergency medicine, visceral surgery and liver transplantation, and thoracic and cardiovascular surgery. His main passion of research is the development and implementation of point-of-care guided algorithms for goal-directed perioperative bleeding management and patient blood management. He has published 91 PubMed-listed papers, as well as numerous abstracts and book chapters. Tonight, he'll be sharing some of his expertise with us, as well as getting us up to speed on the latest and greatest evidence for ROTEM-guided bleeding management across a variety of clinical areas. So without further ado, please welcome Dr. Klaus Goerlinger. Dr. Goerlinger, it's so great to have you here. Thank you so much for joining us tonight.
Yeah, Maggie, thank you very much for your kind introduction. So we just start the slides and just move this a little bit down here. So I hope everybody can see my slides. Yeah, as you already introduced, so we will talk tonight about a ROTEM update in 2020. Maybe you know we have about 200 to 250 new papers every year. And of course, we have not the time to discuss all of them, but maybe the 10% most important new studies. Thank you already for your kind introduction. So I think we can save the time to discuss this again. Of course, most important, my conflict of interest is that I moved in 2012 to the dark side of power, and I'm since then the medical director of the ROTEM company. So why are we talking about ROTEM-guided bleeding management? It's not because it's important by itself, of course. ROTEM-guided bleeding management is a part of patient blood management. And of course, Australia is one of the countries in the world where patient blood management is most implemented. But looking at a paper from Bronwyn Pierce from Queensland, of course, it's still not implemented everywhere. And we know it takes some time, even from guidelines to a clinical practice, which usually takes even between 5 to 10 years. But again, also patient blood management is not about saving blood. It's about patient safety. And this is also not a new idea. It's already more or less 2,500 years old when Hippocrates from Greece defined what you do as a physician. Of course, we want to cure, but first of all, we want to prevent additional harm. And what we learned, of course, in the last 10, 20 or even longer time is that, of course, blood transfusion can be life-saving, but it can also be harmful if it's not done in an appropriate way. The other thing we learned also by using ROTEM in our institution, we started in 1998, that of course you cannot expect that every anesthesiologist or intensivist is an hemostasis expert. And this resulted even in the first 5 years after we started with ROTEM that we published our first algorithm that was for liver transplant in 2006. And the reason for that was, more or less two reasons. One was that even if we define quite a simple step-by-step protocol that also a non-hemostasis expert can run such an algorithm where you more or less have to keep in mind 3 numbers. And second, it was also discussed in the transfusion committee of the hospital. And that means that you talk the same language, which means if you talk to the blood bank, you talk to the lab, you understand each other, what you're talking about. And the last year showed that really the implementation of ROTEM algorithms matters, because just to run a test is not really a big advantage if you don't know what to do with the results. And this is even now with the fully automated ROTEM Sigma, where running a test is not a problem anymore, but interpretation is still the same. So we go through different settings and just start with a trauma setting. And we'll also want to introduce our most updated trauma algorithm. So it's not from a company, but it's from a group of experts. And just the second edition of this textbook, Trauma-Induced Coagulopathy, from Hunter and Ernest Moore. Maybe you know Ernest Moore is the editor-in-chief of the Journal of Trauma. The second edition just has been published after the textbook had been downloaded a lot of times. And all the protocols, if that's for trauma or for livers or for cardiac, of course, start with the clinical situation. That's very important because the ROTEM cannot tell you if the patient is actually bleeding. You have to look at your patient. And if the answer to this first question, if there is diffuse bleeding and blood transfusion has to be considered, is answered with no, the algorithm stops, which means we don't treat numbers. And also, which is important, of course, we also consider other analyses, like blood gas analysis, very important in patient with severe shock. And we know that if the base excess is negative, at least a -6 or even below, the hemoglobin level is low, the injury severity score or test score is high, that means a high risk of bleeding. So again, we don't treat a ROTEM, we treat a patient and also look at other point of care results like blood gas analysis. The next question is, and this, the sequence is not based on how quick you get the results, it's how important is the issue. And therefore hyperthrombolysis is of course very important in trauma. And as you see, of course, it's mentioned if not already given prophylactically. And of course, we don't argue against the CRASH 2 study. If there is severe bleeding, of course, you can give tranexamic acid in the time window of the first 3 hours after injury blindly. But if the bleeding is later or nobody was giving tranexamic acid in the first 3 hours, we can also use early ROTEM variables or the maximalizers to trigger the first or even a repeated dose of tranexamic acid. Then we look at clot firmness. Again, is not based on the sequence we get the results, because of course clotting time we get earlier, but we know that without a substrate, and the substrate is fibrinogen or platelets, you can generate a lot of thrombin, but you will not end up with a stable clot. So therefore we look at the amplitude after 5 minutes in XTEM and FIBTEM, and if both are reduced, so below a cutoff, which has been defined in observational studies and ROC curve analysis in trauma patients, then we consider a fibrinogen replacement, can be fibrinogen concentrate or cryo. And then we can also use this table or an equation, how much fibrinogen we need. And this is also important to do the right dosing. If overall clot firmness in XTEM is reduced, but FIBTEM is fine, or if we even add also platelet function testing, then we have to think about platelet transfusion. If both questions here are answered with no's, which means there's no problem with clot firmness, then we look at thrombin generation. And this is just a reminder to say, okay, clotting time, if it's prolonged more than 80 seconds in the extrinsically activated test, we just double check again. If fibrinogen is high enough, why we do this? It's because we know that if fibrinogen is very low, clotting times are nearly always prolonged. But then we would do the wrong therapy. We would add plasma, which is not a good source for fibrinogen, or even protamine complex concentrate, which doesn't include any fibrinogen. So we have to exclude this. In principle, it's already excluded by the step-by-step. But since we learned that several people already start to treat a prolonged clotting time, not waiting for A5 in FIBTEM, again, this can result maybe in an inappropriate plasma or PCC administration. And this is quite rare. We're just analyzing also some new trauma data to see how often we see, for example, an endogenous heparin effect. We learned that during trauma and shock, there can be a damage to the glycocalyx, but actually we don't really know how often this occurs, but we just have it here in mind that we might have also look at the intrinsic pathway, which again is not very often impaired because in early trauma, there is a lot of liberation of factor VIII from the endothelial cells as a very quick acute phase reaction. And then if we did an intervention, but there's ongoing bleeding, we recheck after about 10 to 15 minutes with a new blood sample and then do the fine tuning. So we just start with a first case. So I just activate what we see here, and which we will also use next year quite often in our workshops, is a pre-recorded cases, which we can run with 20 times speed. And I just want to show this first case, and then afterwards we will start the polling. You have already on the right side, so you can think already during the thermogram is running, which might be not the appropriate intervention. So we have here the choice between tranexamic acid, fibrinogen concentrate, cryoprecipitate, fresh frozen plasma, or idurcizumab. And just as a reminder, you should look here mainly at the clotting times in all 4 tests. You see in the upper line, we have 2 extrinsically activated tests, the XTEM and FIBTEM. In the lower tests here, we have the HEPTEM and INTEM. And it's more or less the video clip is done. So please, Kiernan, can we have the first poll on the screen? Yes. And I would like to ask you to select the not appropriate intervention for this case. We can move this just to the left side that you still can see the thermogram. And after 30 seconds, we will just stop the polling. We just wait what might be the most appropriate or not appropriate intervention. And also when we look at the upper right corner of the slide, there's something about atrial fibrillation. So what does that maybe mean? Why we think about that? This is also an additional important intervention. So most of you said that giving idurcizumab is not the adequate intervention. I would not completely agree with that, because when we look again here at the clotting times, you see that all clotting times, if it's extrinsically or intrinsically, are significantly prolonged. That's a typical picture of a 2A inhibitor. And just see why it's not moving forward anymore. Sorry. Now it does. And there are several studies showing that there's a close correlation between the XTEM or FIBTEM clotting time to the dabigatran plasma concentration. So more or less we can use this to calculate the plasma concentration. Would be in this case a dabigatran concentration about 160 nanograms per milliliter. So in a severe bleeding trauma case, it might make sense to give an antidote to dabigatran. Of course, since the clot firmness was reduced significantly, so we have a trauma-induced scorgropy, it also makes sense to give tranexamic acid. The FIBTEM was definitely low, so fibrinogen substitution was also fine with fibrinogen concentrate or cryo, but fresh frozen plasma will not help against dabigatran. Several studies showed this, and it's also not effective to increase fibrinogen level. So from my point of view, fresh frozen plasma would be here the intervention with the lowest chance for improvement. Of course, we did several studies in the trauma area. This one study published last year, it was part of the European Center TBI trial, which was mainly an observational trial, big observational trial in patients with traumatic brain injury. And we had the chance to run a small interventional trial as a group of this study. And what we decided was to go to 5 hospitals in Europe which never used ROTEM in the trauma setting before. So they were all naive to ROTEM technology, and we implemented ROTEM Sigma, did a 2-day training, which was mainly training them to use an algorithm. And then we were checking, not looking for outcome, because for that the study was too small. It was like an implementation study where we want to look at times, how quickly the results are available, and second, how good they are using, or what was the adherence to the protocol. So when we look at times first, you see that the time to result after hospital admission was in mean 33 minutes for ROTEM Sigma and 71 minutes for standard coagulation tests. Of course, for both, you need a blood sample. So we're also looking at the time to result after blood sampling. And you see that was again 15 minutes for ROTEM Sigma with quite a narrow interquarter range from 10 to 19 minutes, and it was about 40 minutes longer for the standard coagulation tests. Then also the time to treat after admission, because I mentioned already, patients don't stop to bleed when we run a ROTEM. They might stop to bleed when we do the right intervention. And you see the time to treat after admission was in mean 50 minutes, or the time between having the ROTEM results available and the therapy is done was in mean 9 minutes. And that shows that implementing an algorithm which gives you a clear decision points what to do, and not that you need a discussion with the hematologist or whatever person. This reduces the time to treat significantly and allows that really the patient is treated with the first intervention within the golden hour of shock. This was a quite simple protocol we introduced and trained to these study sites. So in the first box, we look what is an indication to give tranexamic acid, again, if it was not already given prophylactically. The same for fibrinogen replacement, so based on the A5 in FibTem and XTEM, as I already explained in our ROTEM algorithm. Then what is the indication for platelets and the indication for 4-factor prothrombin complex concentrate or fresh frozen plasma. And maybe the most important one is if we say 4 times no, because that means the patient doesn't have a trauma-induced coagulopathy. And also that means we don't need a hemostatic intervention. Of course, we may need a surgical intervention, because if there's an open vessel, we cannot close this by giving fibrinogen concentrate. These patients need a suture, a clip, a compression, or something else. And as mentioned, we also measured the adherence to the protocol. And you see, I think training was quite good, because we had an adherence between 87 and a little bit more than 90%. So that means, of course, they could decide not to follow the protocol, but then they had to explain why. And as mentioned before, the most often and most important decision is there is no trauma-induced coagulopathy. And that's in line with the data from a German trauma register, and also with the just published iTactic study, again, a big trauma study, randomized trauma study from Europe, that only about 25% of patients with severe trauma, so in ISS higher than 15, has at admission to the hospital trauma-induced coagulopathy. The other patients, 75%, they have just open vessels. And of course, they need a different intervention. There was another study also published this year, again in traumatic brain injury, but this was powered also for outcomes. And that they also looked at protocol adherence. And you see that was quite similar to our Center TBI trial. It was also 85%. But what did that mean for clinical outcome? They could reduce the incidence of progression of hemorrhagic injury from 48 to 30%, and the need for resurgery so recraniotomy, from 40 to 13%. And I think these are very important outcomes for patients with bleeding in their brain. And so therefore the authors came to the conclusion that the implementation of a ROTEM-based protocol led to a consistent coagulation management, which means we have a standardized interpretation, but an individualized therapy based on the algorithm. It's improved clot quality and decreased the incidence of progression of hemorrhage, which is a very important clinical outcome, and the need for neurosurgical reintervention. So it seems to be that in particular in traumatic brain injury, early stopping bleeding and coagulopathy is very important in this setting. There's another interesting study from this year, it's from Singapore, which compared the sensitivity of different ROTEM tests to hyperformalize, because we know hyperformalize is an important issue in trauma as well as in postpartum hemorrhage. And of course, already two other centers from the US, it's Pittsburgh and also the site from Ernest Moore in Denver showed that FibTem is much more sensitive to formalize. And here, this group again, they showed that when you look at XTEM fibrinolysis with more than 15% lysis within 1 hour, you see in 37 patients from 400 hyperformalisis, where if you use FibTem, you see hyperformalisis in 132 from 400. So that means you detect it much earlier, but the question was, does that also have an impact on outcome? And yes, it has. Again, if we see already formalize in XTEM, we have a mortality of more than 80%. Since hyperformalisis in FibTem detects already milder hyperformalisis, mortality is more than 20%. And if we don't see hyperformalisis in XTEM and FibTem, mortality is only 10%. So it's not just numbers, it has a direct correlation to outcome. Another very important study in trauma, already published in Lancet in 2017, is a RETIC trial. This was a trial which only included patients with trauma-induced coagulopathy, so not all the patients with an ISF higher than 15. And if coagulopathy was detected, then they were randomized to a ROTEM-guided group with coagulation factor concentrate, so mainly fibrinogen concentrate and 4-factor PCC. And the other group was giving huge amounts of fresh frozen plasma, so 15 milliliters per kilogram body weight, or 5 units in an 80-kilogram patient. If bleeding did not stop and coagulopathy was not treated adequately after the first round, a second round could be performed. So then again, in a ROTEM-guided group, running the protocol again, or giving the second dose of 15 milliliters per kilogram body weight plasma in the plasma group. If even the second round failed to stop the bleeding, then they had to do a crossover, which means if bleeding was not stopped by 2 rounds of ROTEM-driven protocol, they got 15 milliliters per kilogram body weight plasma, or even after 30 milliliters per kilogram body weight plasma, bleeding did not stop, they had to move to a ROTEM-guided approach. And this was a main result of this study, also the failure rate or the need for a crossover. And you see that's also what common practice shows, that after the first round, already 76% of patients in the ROTEM group bleeding stopped, and running a second round, further 20% bleeding could be stopped. So the overall failure rate was 4% in the ROTEM group, which needed a plasma transfusion. And in the plasma group, you see even after the second round, only in 48% bleeding could be stopped, or failure rate was 52%. And this was also the reason why this study was stopped early by the ethics committee. And when we look here at the results, looking at the blood products, you see that in the fresh frozen plasma group, and I mentioned already that fresh frozen plasma is not very good to increase the fibrinogen level, despite 30 milliliters per kilogram body weight, 52% needed additional fibrinogen to increase the fibrinogen level and stop the bleeding. And when we also look at platelets, only in 20% of the patients in the coagulation factor concentrate group guided by ROTEM needed platelets, where nearly 50% of the patients in the plasma group not only needed additional fibrinogen, but also needed additional platelet transfusion. And this has also an effect on the incidence of massive transfusion, which was 30% in the fresh frozen plasma group and dropped down to 12% in the ROTEM-guided group, which means 2/3 of all massive transfusion could be avoided by using a ROTEM-guided approach. And when we look at the safety aspects, even if that is not significant, you see that thromboembolic complication happened in 18% of the fresh frozen plasma group and only in 8% of the coagulation factor concentrate group guided by ROTEM. So it's not only more effective, it's also more safe. And since randomized trials usually have a relatively small size because it's quite difficult to run them, we also compare the results from the RETIC trial to real life data from observational or from a cohort study done in Zurich in Switzerland from Donat Spahn's institution, and we see very similar results. So massive transfusion by implementing here in the right group a ROTEM-guided approach reduces massive transfusion from 12 to 4%. So again, 2/3 of massive transfusion could be reduced. Also fresh frozen plasma in the emergency department from 31 to 6%. So it was in the RETIC trial 4%, here it's 6%, again, very close. And overall mortality was reduced from 33 to 22%, or when we look at 24 hours mortality, from 17 to 10%. So here again, the implementation of a goal-directed coagulation management was able to reduce the incidence of massive transfusion, which we know is not good for a patient, as well as fresh frozen plasma and mortality. But what is important in trauma is that we don't wait that the patient has already the first package or the second package transfused. It's really essential that we initiate the first ROTEM analysis as soon as possible after the patient arrived to the hospital or to the emergency room. So it's really important, because if massive transfusion is already done, we cannot avoid it anymore. That has also impact on the new trauma guidelines from the Eastern Association for the Surgery of Trauma from the US. They did their own meta-analysis, and result of their meta-analysis was that utilizing a TEC or ROTEM-guided blood transfusion algorithm, this results in fewer blood product transfusion. It also avoided additional invasive hemostatic intervention like embolization, and it also reduced mortality in trauma patients. So therefore, they came to the conclusion that in patients with ongoing hemorrhage and concern for coagulopathy, they recommend to use a TEC or ROTEM-guided transfusion algorithms to guide blood component transfusion. And this fits to adult trauma patient, adult surgical patient, and patient with critical illness. Why it's always mentioned in the US, adult patients, the reason is that in the US, or US is the only country in the world where viscoelastic testing with TEC or ROTEM is only approved for 21 years upwards. But of course, we have also data for a pediatric trauma patient, which is also very helpful. This is the last big study published just in the Intensive Care Medicine Journal. This is the iTactic study, which was running the last years in Europe, recruiting nearly 400 patients. They were using 3 different protocols for viscoelastic testing, ROTEM or TEC, or standard coagulation lab. So as mentioned, about 400 patients were recruited, and this is important information. Only about 100 patients were coagulopathic. So this is in line what I already mentioned before, that only 1/4 of trauma patients within ISS higher than 15 are coagulopathic. But compared to the RETIC trial, also the non-coagulopathic patients were included, which of course reduces the effect size of this study. And when we look at the primary endpoint, and the primary endpoint was a combination of patient is alive and free of massive transfusion after 24 hours. The study did not show already a significant benefit, but there was already a very interesting trend in a severe traumatic brain injury, where more or less the positive outcome, alive and free of massive transfusion, was twice higher in the viscoelastic testing group compared to the standard lab tests. When we look at the secondary outcome, which was 28 days mortality, and we can discuss if this is maybe a more important outcome than 24 hours mortality, here it's the other way around from the direction. So therefore, viscoelastic testing is better if it's moved to this side because we talk about mortality. And then we see that, more or less only the coagulopathic patients benefit from a ROTEM-guided or tech-guided approach, which is not a big surprise. So more or less reducing mortality by 50%. But in particular, when we go to the severe traumatic brain injury, here it's highly significant with a p-value of 0.016 and a very high effect size. So you see the odds ratio is 0.28. So this is a really strong reduction in 28 days mortality, even if this is not true for the overall population. So also this study can help us to say, yes, of course, we need ROTEM to decide if a patient is coagulopathic or not. And then in particular in the group with traumatic brain injury, to stop bleeding in a very short time has a very significant impact on outcome. Unfortunately, this information you only get in the supplement. But we have here also the same results just as columns. Some people can see this data easier or can interpret this data easier. And you see here again, that's a severe traumatic brain injury with a dramatic decrease in 28-day mortality. So what is the way to go? I think the way to go in the future is to precision medicine, which we, of course, as anesthesiologists and intensivists use all the time for hemodynamic and for ventilation. But I think it's also time to move to precision medicine in hemostasis, which must mean we need a quick but precise diagnosis. This allows us to do a targeted treatment. And of course, this is easier and in more timely manner possible with factor concentrates. And this has a high potential to improve outcome. And this was one of the first algorithms we defined in our international expert group for trauma at the trauma meeting in Philadelphia in 2014. So now moving to postpartum hemorrhage. I think it's very important to keep in mind first that this happens worldwide very often. And this is the bad news that every 2 minutes, one woman dies worldwide due to postpartum hemorrhage. The good news is 98% is preventable. And a lot of people think, okay, this doesn't really apply for us in developed countries like Europe, US, Australia. This might only be important in developing countries, but it's not really true. This is the information from the 2019 impact report from Every Mother Counts Foundation. And they reported that for the first time in history, the US became the only industrialized nation with a rising maternal death rate. And this seems to have also social aspects because this applies most often for Hispanic or for Afro-Americans. And we just see the same in COVID-19, that these people which have not access to all the resources of such an developed country, might have a bad outcome. Going to the algorithm, it also will be published again in the second edition of this textbook in the, should be in mid of December this year. So it's of course also again starts with a clinical situation. So what is the blood loss or estimated blood loss in postpartum hemorrhage? Of course, we can already, based on the woman trial, within the time window of 3 hours after delivery, administer tranexamic acid. Then we look if there is an indication for a second dose of tranexamic acid, again, based on ROTEM parameters. We're looking at clot firmness as in trauma, but we know, or the observational studies showed us, that we should start with fibrinogen replacement earlier, not as an A5 or FIBTEM below 9. In postpartum hemorrhage, we should start as a FIBTEM below 12, and also the target is a little bit higher, so going to about 16 millimeters. It's again based on observational and interventional trials. The need for platelet transfusion is quite rare in postpartum hemorrhage, as well as also the indication to increase thrombin generation. But of course, there are also some rare conditions, for example, in pregnancy as well as in patients with malignancies. Most often they can be an acquired hemophilia. So we just to keep this in mind, because then we have to look at the intrinsic pathway. And if there's ongoing bleeding, again, within about 10 to 15 minutes, we should recheck and do some fine tuning. And that brings us to the second case. And I will just start here the short video clip. And the question for us in this case, with a severe postpartum hemorrhage, with about 1.5 milliliters of estimated blood loss, we have to think what is in this case the most appropriate next step. So should we give fresh frozen plasma? Should we give fibrinogen concentrate or cryoprecipitate? It's a good idea to give recombinant factor 7A, or should we consider first a non-coagulopathic bleeding? So for example, a uterus atony. So then we can also show the next poll, please. Yes, and please vote. So when you see here the corresponding thermogram, so what would be your decision for the next step? You know, the problem is always, we always have to decide quickly in severe bleeding. But if we can base our decision on data, it's just better than just base it on gut feeling. So we will wait the 30 seconds and then we can see what would be your next step to do. Okay, that's very good. And we will see later on again that, like in trauma, even with a blood loss of 1.5 liter, only 1/4 is coagulopathic. And that means it doesn't make sense to give plasma or fibrinogen concentrate in patients where it's just a uterus atony. And this is also part of the guidelines. So we will see this later on. So what is the evidence behind this? This was the OBS-1 study already published 6 years ago. And it just could identify that the FIBTEM A5 was the best discriminator at 1.5 liter of blood loss if the blood loss will continue to more than 2.5 liters, or the need of more than 8 units of blood products, taking red blood cells, plasma, and platelets together. And therefore we use this as a trigger. And you also see that more or less the borderline cases is at about 17. So that's also the reason why we say you should go to a fibrinogen concentration or a FIBTEM A5 as a therapeutic intervention to about 16 to 17. There are 2 big studies, cohort studies done. One is in UK from Liverpool, a hospital with more than 10,000 deliveries per year. So this study from 4 years included 32,000 deliveries. And what we see, about 3% had a blood loss of more than 1,500 milliliters, and about 1/4 showed a coagulopathy with a FIBTEM below 12. In the first part of the study, they compared shock packages versus a ROTEM-guided fibrinogen replacement. And you see they could halve the need for blood products, and they also halved the blood loss after study inclusion from 1.7 liters to 0.8 liters. But more important is clinical outcome. And you see that in the shock package group, giving huge amounts of blood products, there was a nearly 8% of transfusion-associated circulatory overload, which dropped down to 0 in the ROTEM-guided group. It was also associated with a need for ICU admission in 8%, which dropped down to less than 2%. The need for hysterectomy from about 14 to 8%. And they defined massive transfusion here as more than 5 units of red blood cells. Again, half the need for massive transfusion from 23 to 12%. There was no decrease in mortality because there was 0 mortality in both groups. A quite similar study with also a simple ROTEM-guided protocol was also performed at Yale University in the US. Again, 20,000 deliveries. And when we look here at the results, it's also quite similar to the Liverpool study. Hysterectomy was halved. The estimated blood loss, you see that in the ROTEM group, they stopped bleeding within the next 500 milliliters. In Liverpool, it was within the next 800 milliliters. And there was an increase from 1.5 to 3 liters in the non-ROTEM group, which also fits with an increase in blood loss of 1,700 milliliters in Liverpool. They also looked at total avoidance of blood transfusion. And you see that in the non-ROTEM group, only in 5% it could be avoided to give red blood cells because the blood loss even was significantly increased after the study intervention. But in the ROTEM group, nearly 40%, even despite this blood loss of 2 liters, red blood cell transfusion could be avoided completely. In the ROTEM group, also for fresh frozen plasma, only 10% get fresh frozen plasma, and nobody had the need for platelet transfusion. And also when we look at the need for ICU admission, it dropped down from 40 to less than 4%. So again, an avoidance of ICU admission by 90%. No reduction in mortality again, because it was 0 in both groups. But they also looked at reduction of costs, and that's not cost for blood transfusion, that's cost for the whole hospital stay. And of course, it's also important if you need an ICU bed or not, because it's the most expensive bed in the hospital. So this drops down per case from $20,000 to $12,000. What I just did some months ago is just a meta-analysis for 2, I think, important endpoints of these 2 studies. So it's overall 50,000 deliveries. And when we look at hysterectomy, there's a 50% reduction, which is highly significant if we take these 2 studies together. And if we look at ICU admission, you see the risk ratio is 0.13, so 87% reduction in the need for ICU admission, and again, highly significant. Just at the last point for obstetric hemorrhage, what about plasma? Because still a lot of patients treat postpartum hemorrhage like a trauma patient and starting plasma quite early. And this study has been published in a quite high-ranked journal in JAMA. And the question was, what is the effect of plasma transfusion if we give it very early, within the first 60 minutes of postpartum hemorrhage, or later within 2 hours or 3 hours? And the primary endpoint is a composite endpoint as death, hysterectomy, and the need for arterial embolization. And when we look what happens in the first 60 minutes, the composite endpoint, there's no improvement. Giving plasma increases these composite endpoint by 50%. And if you look at mortality, it increases mortality 3 times, from 0.5 to 1.5%. If we give plasma later, even mortality increases 4 times. And if we look at plasma within 3 hours, the composite endpoint here increases 2.5 times. So again, and mortality doubles. So there is not any time point where plasma transfusion resulted in an improvement. Plasma transfusion always resulted in higher mortality and a higher composite endpoint. So that means plasma transfusion has no benefit in postpartum hemorrhage, but it has potential harm. And this was also addressed here from the colleagues from Perth, from Nolan McDonald and Roger Browning, just saying here in this editorial 2 years ago, plasma is not the right intervention to increase the fibrinogen level. It's shown already in several studies. If you are at a hospital with a quite huge number of deliveries, you have to make sure that you have an appropriate source of fibrinogen available. And this can be fibrinogen concentrate or cryoprecipitate, and you should discuss with your blood bank that you have these products available in a short time in a severe postpartum hemorrhage. And this is also reflected here in the algorithm from Perth for postpartum hemorrhage. So we don't go into the details here, but it's more or less following the same sequence as I presented in the beginning. Coming to the liver population, so we have to speed up a little bit to be in time. Again, the algorithm is adjusted to the liver population. So here, thrombolysis is a different story, because most reason, or the most important reason for thrombolysis in the anhepatic phase or atrial perfusion is that there is no liver. So quite often self-limiting. So we are more restrictive with tranexamic acid. We can tolerate lower clot firmness because the cirrhotic patients are adapted to this situation. And also what happens much more often is an endogenous heparin effect. But again, this is most of the time self-limiting. So the need for protamine is very rare, maybe in 1 per mil of this patient population. But it's very important because in a hemostasis in a liver transplant is very dynamic, then to repeat if there's any bleeding or at specific time points. This is a study from Brazil, from Einstein Institute, one of the biggest liver transplant centers in Latin America. And they also implemented our protocol. And you see, not a big surprise, any transfusion drops down, red blood cell transfusion, fresh frozen plasma nearly eliminated. And of course, since they did not use factor concentrates before, of course, there is an increase. It's about 1/3, and in some centers up to 50% of the population. PCC administration, despite a high INR, which is of course typical for a cirrhotic patient, it's not very often needed, about 10%. But what is the outcome? Again, they did not only reduce transfusion, they even reduced thromboembolic events, which were at a low level even before, 6% to less than 4%. Arterial thrombosis, so this is a very important issue in liver transplantation. If you have a hepatic arterial thrombosis, from 3.5 to 1.9%. In hospital mortality, again, already the baseline was very low, 6% to less than 2%. And also length of stay at hospital, that's quite challenging to reduce from 16 days to 11 days for a patient with liver transplantation. These are data from our hospital in Essen, where in between we moved to a fresh frozen plasma free liver transplantation in the last 400 cases. Why no fresh frozen plasma? Because fresh frozen plasma is a huge volume, and one of the biggest triggers for blood loss is portal hypertension. But the question was, moving to factor concentrates, does that increase thromboembolic events? And it showed, no, it does not. But again, platelet transfusion is a big issue. And this is a meta-analysis. 2020 is the years of meta-analysis, which just looked not only at liver transplantation, it's surgery in patients with liver cirrhosis. And nearly every hospital has to deal with these patients. And one of the key outcomes here is that using a thromboelastometry or thromboelastography guided approach significantly reduced intraoperative blood loss, here by at least of 800 milliliters. And the best study was the SMART study, not because the study is smart, the first author's name is SMART, and it's a ROTEM study. And you see even in the ROTEM group, they could reduce blood loss by 2 liters. Moving to the last setting we want to discuss today, it's cardiovascular surgery. Again, of course, it's a specified protocol starting with a clinical situation. Again, we don't want to treat numbers, we want to treat bleeding patients. Thinking about hyperthrombolysis, quite often not so important in cardiovascular because most patients get tranexamic acid prophylactically. Very important, of course, after weaning from bypass and reversing heparin is to check, was that the right protamine dose, or is there residual heparin effect, or even a protamine overdose, which is also not very nice. Looking at clot firmness, and with clot firmness, we are between liver transplant, which have a lower level, which we can accept, and trauma and postpartum hemorrhage with a higher level. Looking at clotting times again, and if there is a need for a reanalysis. This is one of our first study. I just want to point out here, again, it's not just about reduction in transfusion. I think key message of our first study, which was done in nearly 4,000 patients, is half the incidence of massive transfusion, which we know has a negative effect on outcome. Reduce re-expiration, again, this is not healthy for our patients, and as a safety aspect, that was the first study showing that this even result in less thromboembolic complication and not more. And this was a corresponding randomized trial from Frankfurt done with Christian Weber. And we see here again in this very specific population, because that was only the more or less 5% most severest cases, complex cardiac surgery with bleeding after giving protamine. And then they were randomized to a ROTEM group, and which are the blue bars, and the standard coagulation test guided group with the red bars. And you see again significant reduction, massive transfusion, elimination of the rescue therapy with recombinant factor 7A, and clinical outcomes that acute renal failure was reduced from 20 to 6%, septic complications from 14 to 2, thromboembolic events from 4 to 0, and we take this together as a composite adverse events from 38 to 8%. And this finally leads to a significant reduction in 6-month mortality from 20 to 4%. Again, this is not the overall population in cardiac surgery, that are the 5% of severest cases. And this has been repeated again and again from other groups. This is a group from Tuscany, again about 4,000 patients, so not a randomized trial, but reproducing also our before and after study, and this resulted in also adherence to protocol, so more use of ROTEM in bleeding patients. If you just have one but don't use it, will not help, and also more specific therapy in most patients. And you see again a significantly decrease in postoperative acute kidney injury, shorter hospital stay, and reduced costs. And this is a second randomized trial from Germany, published last year, also in cardiac surgery from the biggest centers in Germany, University of Leipzig, German Heart Center in Berlin and in Hamburg. And what they found out is also not a big surprise. Non-bleeding patients don't benefit from running a ROTEM because there's no problem. But bleeding patient, and in particular patient population with a long cardiopulmonary bypass time of more than 115 minutes, they had a significant reduction in 24 hours blood drainage from more than 2 liters to 1.5. And that was the first study even looking at 5-year mortality. And this dropped down from 15 to 0%. So to avoidance of acute kidney injury has a very important impact on long-term survival. And even they could save €600 per patient. So it was a better outcome for less costs. And this is, again, most important for the big procedures also here, like thoracoabdominal aortic aneurysm repair. And there was also in our institution that type A dissections as well as other major aortic surgery has, of course, the highest impact on clinical outcomes as well as costs. And what we see here is that they also reduce the use of fresh frozen plasma significantly from 97% before using ROTEM, nearly everybody got plasma, to only 1/3. But outcome is important again. The incidence of pulmonary complications dropped down from 83 to 44%. So that means before it was normal to give plasma, it was normal that they have pulmonary issues. But by doing a more specific therapy and avoiding plasma, which is not very effective but has side effects like Trali and Taco, they could reduce the complications by, again, about 50%, and had also, again, a significant cost saving. So what does, and that's the last studies I want to show you, what are the endpoints or the outcome in big meta-analysis. That was a Cochrane analysis from 2011 based on 9 RCTs and 700 participants. So that was the first analysis, and Cochrane said what they usually said: we need more data. Then there was 2016, another meta-analysis based on 17 trials, and this showed a significantly improvement in outcome, as also the updated Cochrane analysis from 2016 showed. Again, 17 randomized trials, 1,500 patients, and it showed not already for the TEC, but for the ROTEM, a significant reduction in mortality. Of course, that's just for bleeding patients, but a risk ratio for 0.44. And even if we take TEC and ROTEM together, it's still significant. And again, a significant reduction in the need for dialysis. And that's the last Cochrane, not Cochrane analysis, but meta-analysis from a group from Brazil in 2020. And you see even the number of RCTs increase. That doesn't include the last one from Germany. Also the number of patients from 1,500 to nearly 9,000. And it's still that there's some improvement in TEC, mainly based on the Gonzalez trauma study. But there's still, when we look at ROTEM, a significant reduction with the risk ratio here, which is much higher than the TEC group. And again, if we take TEC and ROTEM together, it's still significant, with at least 46% reduction in mortality. There's also interesting trend, not significance, for thromboembolic events. You see that in the TEC studies, thrombosis increase a little bit, whereas decrease in ROTEM, and if you take both together, there's no change. What might be the reason for that? I think it's not the device, it's the algorithm, because TEC algorithms favor plasma and platelet transfusion, where ROTEM algorithms favors treating hyperthrombolysis first and increasing the fibrinogen level. And that seems to be more safe than giving plasma and platelets first. And again, acute kidney injury are only a small trend in TEC studies, but highly significant in the ROTEM studies. And why is this important? I showed you when you look at 5-year survival in the last German study, there's a significant improvement. And this is mainly based by avoiding acute kidney injury. And this is also a study even looking at 10-year survival, but looking at 5-year survival here again, you see if there's no acute kidney injury after cardiac surgery, more than 90% our patients survive the next 5 years. But if there's any acute kidney injury, even if it's only dialysis for 2 or 3 days, this drops down to 70%. That means more than 20% of our cardiac patients die within the next 5 years if we don't avoid acute kidney injury. This is also reflected now in the US guidelines, which is more or less a copy-paste of our algorithms, which have been published last year from the Society of Cardiovascular Anesthesiologists from the US. There's still a lot of things to do. This is a paper from Bronwyn Pierce from Brisbane, where they still say there's still a wide variation in bleeding management, and there's still room for improvement by implementing a standardized approach of interpretation of the data. So by implementing algorithms based off point of care testing. Also, the use of factor concentrates allows a more correct or precise therapy, and the therapy can be done in a very short time. And we need bleeding management education. We need a multidisciplinary team approach. And of course, if this is supported by the medical societies or even the government, as in Australia, of course, this makes it also more effective. So to summarize, I think ROTEM is a step forward to safer patient care, which is in line with the Helsinki Declaration of Patient Safety in Anesthesiology. There are 3 essential key points for success. This is a quick and precise point of care diagnostics, which can be provided by ROTEM. Of course, we also need rapid, available, and reproducible therapeutic interventions. And I think here factor concentrate have some advantages compared to allogenic blood products from timing as well as from reproducibility. And maybe most important, we need reasonable algorithms with validated triggers and targeted values to link the diagnostic with the therapy. And this is, I think, also represented already 10 years ago by the recommendation from the WHO to implement patient blood management. And as a reminder, they introduced this year the World Patient Safety Day, which will be every year on September 17th. So again, it reminds us we don't just want to reduce blood transfusion. It's all about patient safety. And that's the end of the presentation. Thank you for your attention, and we can start, I think, with the discussion.
Thank you so much, Dr. Goerlinger, for that fantastic presentation. We have gone just a bit over time, so we'll just make time for one quick question. We had a really good question come in from Philip, and his question says, ML takes time. ROTEM estimates ML in advance. We are often intervening based on the A5, then repeating. What is the earliest reliable way to confirm hyperfibrinolysis?
Yeah, the point was, of course, we had this already in mind 5 years ago, that of course waiting for maximum lysis, of course it's a very quick hyperfibrinolysis, we can see it, but usually then we have to look at the thermogram for about 1 hour. And this is, of course, too long time. And therefore, 5 years ago, we did an analysis because in our database, we had more than 400 patients with hyperfibrinolysis and compared this to 2,500 patients without. And we could show that an A5 in XTEM, which is below 35, can already predict 90% of the late lysis. And also, if we have a flat line in FibTem over 5 to 10 minutes, this also is a very good predictor for late lysis. So that means using these cutoff values, which is just exactly the same cutoff values Karin Broe from London defined 10 years ago at trauma-induced coagulopathy, so XTEM A5 below 35. This can already help us to identify, is there, for example, in trauma-induced coagulopathy or not? And if there's no trauma-induced coagulopathy, the chance that we can do something good with tranexamic acid is very low. Again, this doesn't exclude to give tranexamic acid blindly in the first 3 hours. But if for whatever reason the patient gets first to a small hospital, is transferred to the major trauma center, nobody was giving tranexamic acid early, we would only give tranexamic acid out of this time window when we really see a trauma-induced coagulopathy. So we have a very high sensitivity, specificity is lower, so we still will treat maybe 50% patients which will not develop a fibrinolysis, but we are very sure that we catch every patient which has a high risk of fibrinolysis. So that allows us to do this decision within about 10 minutes after starting the test, because we don't want to have a further delay, because waiting 1 hour means maybe we give tranexamic acid then outside of the 3 hours time window. So this helps us to do a decision already before we really see the hyperfibrinolysis within the thermogram.
That's great. Thank you so much. Thanks to all of you who submitted questions, and thank you, Dr. Goerlinger, for your response. Unfortunately, we've run out of time for any more questions tonight, but as I mentioned at the beginning, please post any more questions you have in the Q&A section, and any and all unanswered questions will be published along with answers and provided via email. So thank you, Dr. Goerlinger, once again for your fantastic presentation. Do you have any final comments before we close the Q&A segment of our session?
Yeah, I think more or less it's mentioned in my last slide. Just having a ROTEM or running a ROTEM is not really helpful. Of course, we need education, or people have to understand what they see. We have always to combine it, what is going on in the operational field. And I think the key message is implementing algorithms, which should be quite simple as shown in these cases, allows that you really can do a step-by-step interpretation. And you just have to keep in mind a small 3 to 4 numbers, which should be also possible for the, let's say, standard anesthesiologist intensivist. And this is a key that we really also train people to do it in a standardized approach. Of course, if you're experienced, you look at the thermogram and you see it. But I think for the beginners, students, residents, it's important, like for electrocardiogram or X-ray, to learn to do a standardized interpretation. And this, I think, results in a very appropriate therapy and avoids everything which is not needed.
Thank you so much.
So I hope you see already the slide with the announcement for the activities for next year.
Yes.
Okay.
Yes, thank you for that. So yeah, we did have more questions come through again. So everybody just, we will definitely follow up with you with answers for all of those. So sorry we're running out of time. But thanks to all of you who were able to stay online to this point, as we are now to the exciting final segment of tonight's event, where we'll give you a little preview of what's to come in Emerge 2021. So our events for next year will be a little different to tonight's session in the fact that they will be focused on specific clinical areas, and each one will also be paired with a virtual workshop in the week following the presentations. So in a moment, Dr. Goerlinger is going to show you a video he prepared to provide you with a preview of the simulation workshops. You'll also see that we do already have dates set for these events, and we will be in touch with you to provide you with the registration details closer to the time of the events. Once again, we're really interested in any feedback you may have to help us tailor these events, so please stay tuned for the survey that will appear at the close of this meeting. So I'll now turn it back over to Dr. Goerlinger to tell you about the virtual workshops.
So, okay, so I will try to start the video clip. Oops, I have to first close this one. Sorry. Oh, why it doesn't stop here? This one. So I hope. I want to invite you to our ROTEM. Do you see the video clip already, or?
Not yet.
Not yet. Okay, then I have to stop it here again. So unfortunately, the same problem as we had in the beginning. Okay. I hope now it will. Do you see it now? You to our ROTEM simulation workshop 2021, organized by Werfen Australia. Even with the ROTEM Sigma as a fully automated system, still a lot of clinicians feel uncomfortable with the interpretation of ROTEM results and quick but precise decision-making. And this might be based on human nature, that if you have the chance to choose between a simple but wrong or a complex but right decision, Well, still a lot of colleagues prefer the simple but wrong. And it's like using just fixed ratios for all bleeding patients with a specific ratio between red blood cells, plasma, and platelets, which are quite unlikely to be optimum for all bleeding patients. But they are, of course, much simpler than a goal-directed approach. However, training of the use of evidence-based ROTEM algorithms in a structured way is very important to improve patients' outcome. And this should allow even the non-hemostasis expert to do a structured interpretation and a standardized approach for what kind of therapy might be the best way to stop bleeding in this specific patient as a personalized treatment. Also, simulation training is very important because your simulation dummy may die, but your patient should not. And that means it's better to train this situation, which is not always daily practice, like a severe postpartum hemorrhage, in a simulation rather than to do this if you have faced for the first time this situation in clinical practice. There have been even several studies looking at the effectiveness of monthly trauma simulations and procedural training, and they showed that this was here in a trauma center in the US associated with decreased time to intervention, which is known to have an effect on clinical outcome. And again, this is most important in high acuity but low frequency situations. However, if this is associated with improvements in short-term and long-term patients' outcome, has to be shown in future clinical trials. But also in other situations like postpartum hemorrhage, simulation is more and more used, in particular in institutions where this does not happen every day, or with colleagues which are just at the beginning of their education, like students or residents. But it can also be part of a quality improvement project. So the interest in simulation also in obstetric hemorrhage is significantly increasing during the last years. And I think a structured approach is definitely better than the panic approach. Just open the fridge and transfuse everything which is inside. So for this reason, we already started years ago to run hands-on simulation courses like this one in Brisbane, at the Royal Brisbane. But this has been done in the past most often as a hands-on simulation in the simulation operation theater with blood samples, which we spiked so to reproduce coagulopathies, and where there also was the option to treat this coagulopathy with real blood products or factor concentrates. Of course, now in times of COVID-19, hands-on workshops are actually not possible to perform, but we have in between also quite a lot of experience in running simulations with online interpretation workshops. And here we train the participants in using evidence-based ROTEM algorithms in a structured way, always starting with the clinical situation, then step by step decide which intervention has the highest chance to stop the bleeding. And for this, we are using pre-recorded thermograms as short video clips. And we can use this again to simulate the baseline coagulopathy as well as the therapeutic interventions. So again, welcome to Success and enjoy the journey with us in our online simulation workshops in 2021. And I hope to see you again soon.
Thank you so much, Dr. Goerlinger. Thank you for joining us tonight. Your expertise is is so well appreciated and helpful for a lot of our different sites here in Australia. So thank you so much. We've now reached the end of our first Emerge event. Sorry that we've kept you guys a bit past time, but we hope you all found this meeting to be thought-provoking and informative. Thank you again so much for taking time out of your busy evenings to join us tonight. We really look forward to receiving your feedback on this session, and we can't wait to see you at next year's events. Once again, I'm Maggie Harrington, and from our whole Warfarin Australia team, we hope you all stay safe, take good care, and have a fun and relaxing holiday season ahead to wrap up this truly unprecedented year. Thank you so much.
Bye-bye, and see you next year, hopefully.
Thank you. Thank you, Klaus.